Anatomy, Histology, Embryology, and Developmental Anomalies of the Pancreas Megha S. Mehta, Bradley A. Barth, Sohail Z. Hussain 55 History of the Pancreas. Although the identity of the pancreas has been known for some time, its critical digestive functions were only recently appreciated. 1,2 The first description of the pancreas was made by the Greek physician Hierophilos at around 300 BC. In the late 1st century another Greek authority, Rufus of Ephesus, named the organ the pancreas. The term literally means all flesh or meat, which distinguished it from bone or cartilage. Unfortunately, the name calicreus, meaning beautiful flesh, given to the organ by Galen around the same time or shortly after Rufus, was not adopted. Nonetheless, Galen thought the pancreas served to support and protect overlying blood vessels. In the Talmud, the central text of Jewish law, the pancreas was referred to as the finger of the liver. Vesalius considered the organ a cushion for the stomach. In 1642, Wirsung characterized the pancreatic ducts of humans, and in 1664, de Graaf discovered pancreatic secretions from the pancreatic fistula of dogs. The digestive action of pancreatic secretions was discovered almost 200 years later. Eberle in 1834, Pourcanier and Pappenheim in 1836, and Valentin in 1844 observed that pancreatic juice emulsified fat, proteolized proteins, and digested starch, respectively. Bernard subsequently demonstrated the combined digestive action of pancreatic juice using secretions from pancreatic fistula preparations. In 1876, Kuhn introduced the term enzyme and was the first to isolate trypsin. The concept of enzymes quickly led to the identification of pancreatic amylase and lipase. In 1889, Shepovalnikov, a student of Pavlov, discovered enterokinase in the duodenal mucosa, an enzyme that is essential for activating trypsin and the subsequent cascade of other digestive proteases. In 1895, Dolinsky, another of Pavlov's students, stimulated pancreatic secretion by instilling acid into the duodenum. This led to the discovery of secretin in 1902 by Bayliss and Starling, which was the first hormone ever to be identified. 3 The histologic structure of the pancreas was first described in 1869 by Langerhans. Shortly thereafter, Heidenhain found that as the granular region of pancreatic acinar cells disappeared after feeding, enzymatic activity in pancreatic juice inversely increased. He correctly concluded that the granules contained digestive enzyme precursors, or zymogens. In 1875, Friedreich wrote the first systematic description of pancreatic diseases, followed by a classic account by Fitz on acute pancreatitis in 1889. 4 The pancreas first came to the attention of the Nobel Committee in 1905. When Ivan Pavlov was awarded the prize for his work on the physiology of digestion, with particular emphasis on neural control of the stomach and pancreas. In 1923, Canadians Frederick Banting and John MacLeod were awarded the prize for successfully purifying insulin from the pancreas of dogs. It is notable that a medical student, Charles Best, was a CO discoverer and shared the prize money with MacLeod. In 1946, John Northrop CO shared the Nobel Prize for his work on purifying enzymes in their crystalline form. Among the pancreatic enzymes, he managed to crystallize trypsin, chymotrypsin, and carboxypeptidase. In 1958, Frederick Sanger received his first Nobel Prize for determining the structure of insulin. Sanger, however, is best known for his second Nobel Prize, in 1980, for developing a signature method for sequencing DNA. In 1974, George Palade, along with Albert Claude and Christian de Duva, received the Nobel Prize for making seminal discoveries in cell biology. Palade used the pancreatic acinar cell, in combination with newly developed techniques of differential centrifugation, electron microscopy, and pulse chase, to describe the role of ribosomes along the endoplasmic reticulum, rough ER, in synthesizing proteins and the transit of proteins through the Golgi apparatus into secretory pathways. 5 In 1977, Rosalind Yallo received the prize for the development of radioimmunoassays of peptide hormones, in which the prototype was insulin. She worked with Solomon Berson, but he unfortunately died before the Nobel Prize was awarded. Most recently, Günter Blobel won the prize in 1999 for his work using pancreatic acinar cells to discover intrinsic signaling mechanisms governing intracellular protein transport and localization. These awards demonstrate how the study of the pancreas continues to advance major scientific development. Anatomy: the pancreas is a soft, elongated, flattened gland that is 12 to 20 cm in length. 6 The adult gland weighs between 70 and 110 grams. The pancreas is coarsely lobulated and covered with fine connective tissue, without a true capsule. It is primarily retroperitoneal, lying approximately at the level of the L1-L2 lumbar vertebrae. The head of the pancreas is on the right, lying within the curvature of the duodenum, and the remainder of the pancreas lies obliquely in the posterior abdomen, with the tail extending as far as the gastric surface of the spleen, Fig. 55.1. The anterior surface of the head of the pancreas is adjacent to the pylorus, the first part of the duodenum, and the transverse colon. The posterior surface abuts the hilum and medial border of the right kidney, the inferior vena cava and the right renal vessels, the right gonadal vein, and the right crus of the diaphragm. The uncinate process, lingula, is a prolongation of pancreatic tissue that projects off the lower part of the pancreatic head, extending upward and to the left. The uncinate process lies anterior to the aorta and inferior vena cava and is covered superiorly by the superior mesenteric vessels that emerge below the neck of the pancreas. There is much variation in the size and shape of the uncinate process, and it may even be absent altogether. The neck of the pancreas is a constricted part of the gland, extending from the head of the pancreas toward the left to connect the head with the body of the pancreas. It is 1.5 to 2 cm long and 3 to 4 cm wide. Posterior to the neck of the pancreas lies the confluence of the portal vein with the superior mesenteric and splenic veins. Anteriorly it is covered in part by the pylorus and peritoneum of the lesser sac. The neck extends to the right as far as the antero-superior pancreaticoduodenal artery from the gastroduodenal artery. The body of the pancreas runs toward the left side, anterior to the aorta. It is retroperitoneal and held against the aorta by the peritoneum of the lesser sac. The anterior surface of the body is covered by peritoneum of the omental bursa, which separates the stomach from the pancreas. The antrum and body of the stomach and the transverse mesocolon contact the body anteriorly. Posterior to the body of the pancreas are the aorta, the origin of the superior mesenteric artery, the left crus of the diaphragm, the left kidney, the left adrenal gland, and the splenic vein. The midline part of the body overlies the lumbar spine, which makes this area of the pancreas most vulnerable to abdominal trauma. The body passes laterally and merges with the tail of the pancreas, without a discernible junction point. The tail is relatively mobile, with its tip usually reaching the hilum of the spleen. It is defined somewhat arbitrarily, beginning halfway from the distance of the left border of the mesenteric vessels and extending to the tip of the pancreas. The tip of the tail is intraperitoneal, lying between layers of the sphenorenal ligament. The relationship of the pancreas to important structures in the posterior abdomen is seen in Fig. 55.2. Ductal structures: the main pancreatic duct, of Wirsung, begins near the tail of the pancreas. It is formed from anastomosing ductules draining the lobules of the gland. It courses left to right and is enlarged by additional ducts. Through the tail and body, the duct lies midway between the superior and inferior margins and slightly posterior. The main duct turns caudal and posterior on reaching the head of the pancreas. At the level of the major papilla, the duct turns horizontally to join in most cases with the bile duct, Fig. 55.3a. The duct of Wirsung and the common bile duct empty into the duodenum obliquely via the major papilla. The ampulla of Fata is the common pancreaticobiliary channel within the papilla where the two ducts come together, separated by common hepatic artery, splenic artery, tail, portal vein, bile duct, superior pancreaticoduodenal artery, inferior pancreaticoduodenal artery, uncinate process, superior mesenteric vein, superior mesenteric artery, body, neck, head, splenic vein, superior mesenteric artery, superior mesenteric vein, portal vein, bile duct, hepatic celiac artery. AB Fig 55.1 Anatomic relationships of the pancreas. A. Anterior view. B. Posterior view. PCLAVKISG Fig 55.2 CT showing the normal anatomic relation of the pancreas with other intra-abdominal structures. The borders of the pancreas are indicated by arrowheads. The splenic vein is indicated by an arrow. A. Aorta. C. Vena cava. G. Incidental gallstone. I. Small intestine. K. Left kidney. L. Liver. P. Portal vein. S. Stomach. V. Vertebra. Courtesy MP. Federal, MD. 844 Part 7 Pancreas adventitia. The length of the common channel, when present, averages 4.5 mm, with a range of 1 to 12 mm. 7,83 circular muscle bundles, collectively called the sphincter of Oddi, act as sphincters encircling each duct as well as the ampulla of Fata. The relationship of the bile duct and the duct of Wirsung at the papilla is complex. 9-11 By autopsy and ERCP studies, it appears that about 2/3 to 3/4 of the general population has a common channel, whereas about 1/5 have completely separate openings and just under 10% have an interposed sputum that separates the two ducts. Long common channels or pancreaticobiliary malunion can predispose to pancreatitis or biliary cancer. Approximately 70% of the general population has a patent accessory duct, of Santorini, which is also known as the minor duct. See Fig 55.3a. Point 12 The accessory duct lies anterior to the bile duct and drains into the minor papilla, which lies proximal to the major papilla, but is also located in the second portion of the duodenum. Up to 10% of people have an interruption between the major papilla and the main duct, with drainage into the duodenum occurring via the minor papilla. This variant is called pancreas divisum, see Fig 55.3b, discussed later. A number of other variations in the ducts are encountered. The main pancreatic duct is widest at the head of the pancreas, and the duct gradually tapers as it progresses to the tail. 13 Upper limits of normal for the pancreatic duct diameter in the head, 5 mm, body, 4 mm, and tail, 3 mm, are generally accepted, although there are variations based on age in pediatric patients. Table 55.1. Point 14-17 It is important to know the normal size range of the pancreatic duct in order to discern abnormal ductal dilation or narrowing, as in chronic pancreatitis. Circulation The pancreas has a rich circulation that is derived from branches of the celiac and superior mesenteric arteries. 6 The head of the pancreas and surrounding duodenum are supplied by two pancreaticoduodenal arterial arcades. They are formed by the anterior and posterior superior pancreaticoduodenal arteries from the hepatic branch of the celiac artery that join a second pair of anterior and posterior inferior pancreaticoduodenal arteries branching from the superior mesenteric artery. All of the major pancreatic arteries lie posterior to the ducts. The course of the splenic artery is posterior to the body and tail and loops above and below the superior margin of the pancreas. It gives off the dorsal pancreatic artery, which usually joins one of the posterior superior arcades after giving off the inferior pancreatic artery. The caudal pancreatic artery arises from the left gastroepiploic artery or from a splenic branch at the spleen. It joins with branches of the splenic and great pancreatic arteries and other pancreatic arteries. The rich circulation allows the pancreas to expeditiously carry out its key endocrine functions of maintaining glucose homeostasis by sensing blood glucose concentrations and controlling the release of other hormones from the islets. In general, the venous drainage of the pancreas is similar to the arterial blood supply. It flows into the portal venous system, which is formed by the joining of the superior mesenteric and splenic veins at the confluence behind the neck of the pancreas. The portal vein lies behind the pancreas and in front of the inferior vena cava. The common bile duct lies anterior to the portal vein with the hepatic artery to the left of the common bile duct. The splenic vein originates at the hilum of the spleen and curves behind the tail of the pancreas and below the splenic artery, to the right along the posterior surface of the pancreas. The pancreatic veins drain the neck, body, and tail of the pancreas and join the splenic vein. The pancreaticoduodenal veins lie close to their corresponding arteries and empty into the splenic or portal veins. Because of the close anatomic relationship of the splenic vein with the pancreas, inflammatory or neoplastic diseases involving the pancreatic body and tail can lead to splenic vein occlusion. This in turn can result in retrograde venous drainage toward the splenic hilum and then, by way of flow through the short gastric and left gastroepiploic veins, can create gastric varices. Lymphatic drainage. The lymphatics, in general, drain the surface network of lymph toward regional nodes and are formed near the larger blood bile duct, pancreatic duct, major papilla, cystic duct, accessory papilla, AB Fig 55.3. Anatomic arrangements of the pancreatic duct system. A. The most common arrangement. Most of the pancreatic secretion empties into the duodenum along with bile through the major papilla. The proximal portion of the embryonic dorsal pancreatic duct remains patent in about 70% of adults and empties through the accessory papilla. B. Pancreas divisum. The embryonic dorsal and ventral ducts fail to fuse. Most of the pancreatic secretion empties through the accessory papilla. Only pancreatic secretions from the uncinate process and part of the head of the pancreas, which are derived from the embryonic ventral pancreas, drain through the major papilla. Table 55.1 Average age-related pediatric pancreatic duct size, based on USH, years, PD duct size at body, mm, average plus or minus SD, 1 to 3 1.13 plus or minus 0.154 to 6 1.35 plus or minus 0.157 to 9 1.67 plus or minus 0.17 10 to 12 1.78 plus or minus 0.17 13 to 15 1.92 plus or minus 0.18 16 to 18 2.05 plus or minus 0.15 Data from Chow, H.C., Lin S.J., Kong M.S., ETAL sonographic evaluation of the pancreatic duct in normal children and children with pancreatitis. J. Ultrasound Med 2000, 19:757-63. Chapter 55 Anatomy, Histology, Embryology, and Developmental Anomalies of the Pancreas 845-55 Vessels. 18 They begin as small periacinar and perilobular capillary networks that drain into larger ducts alongside pancreatic blood vessels. The superior lymphatic vessels run along the upper border of the pancreas closely with the splenic blood vessels, whereas inferior lymphatic vessels run with the inferior pancreatic artery. Superior and inferior lymphatic vessels draining the left pancreas, including the tail of the pancreas and left half of the body, empty into nodes in the splenic hilum. The superior lymphatic vessels draining the right pancreas, including the neck and right half of the body, empty into nodes near the upper border of the head of the pancreas. These nodes also receive tributaries from the anterior and posterior pancreatic surfaces. The remaining regions of the neck and body drain toward the right. Overall, the extensive network of blood vessels and lymphatics, as well as the ability of tumors to induce angio and lymphangiogenesis, provide ample avenues for pancreatic cancer to metastasize. 19 Innervation. The visceral efferent innervation of the pancreas is through the vagi and the splanchnic nerves by way of the hepatic and celiac plexuses. The efferent fibers of the vagi pass through these plexuses without synapsing and terminate in parasympathetic ganglia found in the interlobular septa of the pancreas. The postganglionic fibers innervate acini, islets, and ducts. The bodies of the preganglionic neurons of the sympathetic efferent nerves originate in the lateral gray matter of the thoracic and lumbar spinal cord. The bodies of the postganglionic sympathetic neurons are in the great plexuses of the abdomen. Their postganglionic fibers innervate only blood vessels. The autonomic fibers, both efferent and afferent, are located in proximity to the blood vessels of the pancreas. The vagi also carry some visceral afferent fibers. Histology and ultrastructure. The pancreas is a compound, finely nodular gland that in its contour bears some resemblance to the salivary glands. The lobules are visible on gross examination and are connected by connective tissue septa that contain the ducts, blood vessels, lymphatics, and nerves. The basic subunit of the exocrine portion is the acinus, which is at its base a spherical mass of dark staining secretory cells called acinar cells, Fig 55.4. The spherical acinus connects to a goblet-shaped neck that is composed of tubular cells called duct cells. The inner lumen of the acinus forms the terminal portion of the secretory duct. Corrosive casts of the ductular system formed by retrograde injection of latex demonstrate that there is an extensive network of ducts of increasing size that drain pancreatic secretions from the acinar lumen, through intralobular, interlobular, interlobar, and finally into the main pancreatic duct. Fig 55.5.20. The pancreatic ductal system is non-striated and is lined by columnar epithelium. Goblet cells and occasional argentophane cells are also present. The larger ducts have a thick wall consisting of connective tissue and elastic fibers. The endocrine portion consists of the islets of Langerhans, which on H&E staining are spherical clusters of light staining cells. A more detailed description of each of the main parenchymal cells of the pancreas reveals remarkable structure-function relationships. By light microscopy, acinar cells are tall pyramidal or columnar epithelial cells, with their broad bases on a basal lamina and their apices converging on a central lumen. In the resting state, numerous eosinophilic zymogen granules fill the apical portion of the cell. The basal portion of the cells contains one or two centrally located, spherical nuclei and basophilic cytoplasm. The Golgi complex lies between the nucleus and zymogen granules and can be seen as a clear, non-staining region. AIDZG's Fig 55.4. Histology of the pancreas. Top, low-power histologic section of the pancreas showing a ductule, D, an islet, I, H and E. Bottom, a higher power section, showing numerous acini, A, which contain eosinophilic zymogen granules, ZGs. Courtesy Abrahimi Arabi. 300 Fig 55.5. Scanning electron micrographs of the exocrine pancreatic ductal system obtained after filling the pancreatic duct with latex and digesting away the pancreatic tissue. The smallest radicals of the ductal system are connected to acini. The right panel is a magnified image. From Ashizawa N., Watanabe M., Fukumoto S., ETAL. Scanning electron microscopic observations of three-dimensional structure of the rat pancreatic duct. Pancreas 1991, 6:542-50. 846 Part 7. Pancreas. The subcellular structure of the acinar cells can be visualized by electron microscopy, Fig 55.6. The most prominent feature of the acinar cell is the dense zymogen granules that are concentrated in the apical pole. Tight junctions form a belt-like band around the apical end of the cell and are produced by the apposition of the external membrane leaflets of neighboring cells. These junctions prevent the reflux of secreted substances from the duct into the intercellular space. 21 Gap junctions, which allow intercellular flow of small molecules, are distributed on the lateral cellular membranes and are formed by the apposition of larger, disc-shaped membrane plaques. Mitochondria are elongate cylindrical structures that appear oval in cross-section and contain well-developed cristae and matrix granules, Fig 55.7. They are concentrated in several parts of the acinar cells, including as a belt around the zymogen granules, the nucleus, and the basolateral membrane. 22 Rough ER occupies about 20% of the cell volume. 23 It takes up most of the basal region of the acinar cells and interdigitates with the zymogen granules in the apical region. This abundance of rough ER allows the acinar cell to synthesize more protein than any other parenchymal cell in the body. 24 The Golgi complex consists of flattened, membranous SACCules, as well as small vesicles that contain flocculent electron-dense material. The Golgi plays an important role in the transport of secretory proteins and the formation of zymogen granules from maturing condensing vacuoles. Studies of the chemical composition of the zymogen granules have shown that they contain 12 to 15 different digestive enzymes, which make up about 90% of the granule protein. 25 The acinar cells undergo cyclic changes in morphology in response to meals. 26 After a large meal, the zymogen granules are quickly emptied into the acinar duct lumen by a specialized form of regulated secretion called sequential compound exocytosis. 27,28 In this scenario, there is an initial fusion of zymogen granules with the apical plasma membrane, followed by sequential granule-granule fusion events that connect together multiple vesicles to the apical lumen in a beads-on-a string formation. This process solves the problem of rapidly emptying large amounts of granule contents from a relatively small region of the cell. The apical membrane of the acinar cell constitutes only a small portion of total plasma membrane, but its surface area is expanded by several short, slender microvilli that are about 0.2 μm in length and extend into the lumen of the acinus, Fig. 55.8. Thin filaments form the axis of the microvilli as well as a network beneath the apical plasmalemma. The lumen typically contains flocculent electron-dense material that represents the secreted digestive enzymes. Morphologically distinct cells, called centroacinar cells, bridge acinar cells with the ductal epithelium. These centroacinar cells are pale staining on H&E staining and smaller than the acinar cells. Along the basal surface of the acinar cells, but not extending between adjacent cells, is a thin basal lamina, below which nucleum ZG's Fig. 55.6 electron micrograph of a pancreatic acinus showing acinar cells surrounding a central lumen, lum. The acinar cell nucleus, nuc, and ZGs are easily identified, times 3200. Courtesy Ibrahimi Arabi. Go MZG rare Fig. 55.7 electron micrograph of portions of an acinar cell. The top panel represents a basolateral region showing sheets of rough endoplasmic reticulum, rare. The bottom panel also shows a Golgi complex, Go, mitochondria, M, and a ZG, times 43,000. Courtesy Ibrahimi Arabi. MVZG CAC Lum Fig. 55.8 electron micrograph of a centroacinar cell, CAC, and acinar cells surrounding a central lumen, lum. Times 9000. MV, microvilli, ZG, zymogen granule. Courtesy Ibrahimi Arabi. Chapter 55 Anatomy, Histology, Embryology, and Developmental Anomalies of the Pancreas 847-55 are collagen fibers in a rich capillary network. Efferent nerve fibers, derived from the sympathetic and parasympathetic systems, penetrate the basal lamina and terminate adjacent to the acinar cells. The collagen fibers and other extracellular matrix proteins are secreted by a less common resident cell type, the pancreatic stellate cell, PSC. 29 In the quiescent state, the PSC has baseline functions of maintaining the pancreatic microarchitecture and even facilitating acinar cell secretion. In its activated state during pancreatic injury and inflammation, however, it transforms into myofibroblast-like cells that help replenish the matrix necessary for recovery, or it may even serve as a facultative progenitor cell. With persistent injury, it can also cause harm by inducing fibrosis due to increased deposition of extracellular matrix proteins, leading to chronic pancreatitis. See Chapter 59. The PSC also participates in providing an abundant stromal environment around a pancreatic adenocarcinoma, which can limit the effect of cancer therapies. Finally, PSCs can also accompany cancer cells to metastatic sites to facilitate cancer progression. 30 The duct cells have electron-lucent cytoplasm containing few cytoplasmic organelles. 31 They typically contain free ribosomes that are abundant in small, round mitochondria. The prevalence of mitochondria is necessary for allowing the duct cells to carry out their primary function of active ion transport. 32 Whereas the acinar cells secrete small amounts of sodium chloride-rich fluid, the duct cells absorb the chloride and actively secrete bicarbonate and water to provide the bulk of pancreatic juice. The bicarbonate secreted into the intestine neutralizes gastric acid and provides an optimal buffered pH for digestive enzyme function. Several enzymes and a multitude of ion channels within the duct cells orchestrate this net bicarbonate and water secretion. They include carbonic anhydrase and the CFTR. The former enzyme can be used to label duct cells. Severe defects in CFTR cause pancreatic duct plugging during pancreatic development and intrauterine destruction of the exocrine pancreas, with formation of cysts and fibrosis, hence the name coined for the disorder is cystic fibrosis, see Chapter 57. The islets of Langerhans number about 1 million in the human pancreas. Islets consist of anastomosing cords of polygonal endocrine cells, see Fig 55.4. Each islet is about 0.2 mm in diameter, much larger than an acinus, and separated from the surrounding exocrine tissue by fine connective tissue fibers that are continuous with those of the exocrine gland. Each islet is surrounded and penetrated by a rich network of capillaries lined by a fenestrated endothelium. The capillaries are arranged in a portal system that conveys blood from the islets to the acinar cells, Fig 55.9. This islet-acinar portal axis consists of afferent arterioles that enter the islet, form a capillary glomerulus, and leave the islet as efferent capillaries passing into the exocrine tissue. 3335 A parallel arterial system supplies blood directly to the exocrine pancreas, and yet this portal system permits the local action of islet hormones, especially insulin, on the exocrine pancreas. Acinar cells surrounding islets of Langerhans, periinsular acini, are morphologically and biochemically different from acini situated farther away, teleinsular acini. Periinsular acini have larger cells, nuclei, and zymogen granule regions and different proportions of some of the digestive enzymes. The differences appear to be related to the findings that acinar cells express insulin receptors and that insulin influences acinar growth and secretion. There are 5 major cell types in the endocrine pancreas. Beta cells are the most numerous, constituting about 50% to 80% of the islets. They secrete insulin and amylin. PP cells, also known as F cells, make up 10% to 35% and secrete pancreatic polypeptide and adrenomedullin. Alpha cells make up 5% to 20% and secrete glucagon. The remaining 5% consists of delta cells, which secrete somatostatin, and epsilon cells, which secrete ghrelin. Other rarer subpopulations of islets make additional hormones such as ghrelin. Development of the pancreas. Embryonic and fetal development. The pancreas arises from posterior foregut endoderm. 36 Two buds form, one dorsal and one bilobed ventral bud. About a month into gestation, the foregut evaginates into a condensation of overlying mesenchyme to form the first morphologic evidence of the dorsal bud. About a week later, a ventral bud forms as an outpouching of hepatic diverticulum. The ventral bud has a bilobed origin, of which the left ventral bud gradually regresses. 37 Both dorsal and ventral buds undergo elongation of a stalk region and branched morphogenesis. At 37 to 42 days into gestation, as the duodenum grows, the ventral pancreas rotates around the duodenum and fuses with the dorsal pancreas, Fig 55.10. The dorsal pancreas forms the tail, body, and superior portion of the pancreatic head. It also contains the dorsal duct that forms the distal portion of the main pancreatic duct, of Wirsung, and the entire minor accessory duct, of Santorini. The ventral pancreas forms the uncinate process and the inferior part of the head. The ventral pancreas's ventral duct forms the proximal portion of the main pancreatic duct, of Wirsung. As mentioned earlier, the two duct systems corresponding to the ventral and dorsal buds fail to fuse in up to 10% of the general population. In this situation, pancreas divisum, the accessory duct, functions as the main conduit for drainage of pancreatic juice. The clinical significance of pancreas divisum is discussed later. Failure of the ventral pancreas to fully rotate around the duodenum, or persistence of the left ventral bud, can lead to an annular pancreas, also discussed later. After the pancreatic buds fuse, the cellular architecture of the pancreas rapidly expands. Notably, all 3 functionally distinct parenchymal cell types, acinar, duct, and islet cells, differentiate from a common pancreatic progenitor lineage. Classic studies by Rutter and colleagues have divided pancreatic differentiation into 2 distinct phases. 38 The first, termed the primary transition, is defined as the conversion of pre-differentiated cells to a proto-differentiated state in which low levels of pancreas-specific proteins are present. The second phase, or the secondary transition, is marked by a dramatic rise in pancreatic cell number and pancreas-specific protein synthesis, as well as an acceleration in both exocrine and endocrine differentiation. The pancreatic acinar cells at this stage develop their characteristic abundance of islet acini. Fig 55.9 schematic diagram of the insulocinar portal system illustrating the dual blood supply to the exocrine pancreas. From Goldfein ID, Williams J.A. Receptors for insulin and CCK in the acinar pancreas, relationship to hormone action. Int Rev Cital 1983, 85:1. 848 Part 7 Pancreas and dense apically localized zymogen granules. 39 Although the dorsal pancreas arises before the ventral, both appear to exhibit simultaneous exocrine differentiation according to the two phases. 40 In the ontogeny of endocrine cells, glucagon-positive alpha cells initially predominate. 41 After the secondary transition, however, insulin-positive beta cells outnumber all other endocrine cell types. In addition, a remarkable morphologic transformation occurs in the endocrine lineage. Although they start off as epithelial cells, it is thought that at this point in development, instead of dividing parallel to the basement membrane, they begin to divide perpendicular to it and eventually develop into islet units. 39 The newly oriented cell descendants lose their tight junctions and connections to the lumen. The endocrine lineage ultimately undergoes a complete epithelial to mesenchymal transformation, which is a process that to this day ranks among the great wonders in developmental biology and at the same time poses a major problem of metastasis in cancer biology. 42 Transcription factors and extrinsic signals. The sequence and signaling factors that guide pancreatic development appear to be strikingly similar across vertebrate species, differing mostly in the time to organ formation. Indeed, much of our knowledge base is derived from descriptions of mouse development and the ability to perform lineage tracing experiments by exploiting transgenic mice. Nonetheless, there is a perpetual need to confirm animal models of development from our observations of the human condition. 43 Research in this field is swiftly evolving. Here, we highlight some notable mechanisms of development. The morphologic changes in the pancreas and the cellular growth, expansion, and differentiation of pancreatic progenitors are orchestrated by hierarchical signals from two distinct sources, from within the genome of the cells of the pancreas, notably by a host of transcription factors. 44 And from tissues and structures adjacent to the forming pancreas. Each will be discussed. Transcription factors are proteins that bind to specific DNA sequences. 45 They function to either activate or suppress the recruitment of RNA polymerases that are required for transcription. Transcription factors are classified according to their DNA binding domains. A summary of a few of the key transcription factors in pancreas development is provided. Pancreatic and duodenal homeobox 1, PDX1, also known as insulin promoter factor 1, IPF1, or islet/duodenum homeobox 1, IDX1, is the earliest pancreas-specific transcription factor, detected at 5 weeks of development, before bud formation. 46,47 Thus PDX1 is used as a marker of early pancreatic progenitors. Studies of pancreatic development frequently target the PDX1 gene promoter for pancreas-specific expression. For example, in the ventral foregut, expression of PDX1 promotes development of the ventral pancreas. In comparison, expression of SOX17 without PDX1 promotes development of the nearby extrahepatic bile duct. Deletion of PDX1 in MICE48 and humans 49 leads to pancreatic agenesis, discussed later, highlighting its importance in morphogenesis. PDX1 deficiency prevents the pancreatic epithelium from responding to mesenchymal growth-promoting signals. 50 During adulthood, PDX1 expression becomes largely confined to the beta cells, where it maintains beta cell identity and binds to and activates the insulin promoter. 46,51 Conditional inactivation of PDX1 in adult mouse beta cells results in diabetes mellitus. 52 Thus PDX1 is required for proper pancreas development as well as beta cell function. The alpha subunit of pancreas-specific transcription factor 1, PTF1-alpha, also known as P48, is a basic helix-loop helix protein that functions as part of a trimeric protein complex, PTF1 complex. In the regulation of exocrine gene expression. 53 It is initially co-expressed with PDX1 and supports the specification of all three pancreatic cell type precursors, but later becomes confined to acinar cells. 54,55 PTF1A deficiency in mice results in pancreatic agenesis with complete absence of exocrine development, but ectopic endocrine cells can still be found. 56 In a human pedigree, Fig 55.10 stages in the embryonic development of the pancreas. A. At about 4 weeks of gestation, dorsal and ventral buds are formed from the foregut. B. At about 6 weeks the ventral pancreas extends toward the larger dorsal pancreas. C. By about 7 weeks, fusion of the dorsal and ventral pancreas has occurred and ductular anastomosis is beginning. D. At birth, the pancreas is a single organ, and ductular anastomosis is complete. Modified from Ari L.B. Developmental Anatomy, a textbook and laboratory manual of embryology 7th ed. Philadelphia, C.D.W.B. Saunders, 1974. A.B. Common duct dorsal pancreas gallbladder ventral pancreas anastomosis of ducts dorsal pancreas ventral pancreas gallbladder common duct ventral pancreas dorsal pancreas accessory papilla duodenal papilla accessory duct main pancreatic duct head of pancreas Chapter 55 Anatomy, Histology, Embryology, and Developmental Anomalies of the Pancreas 849-55 A truncating single nucleotide mutation in PTF1-alpha led to pancreatic and cerebellar agenesis. 57 Human homeobox. Gene 9, HLXB9, also known as motor neuron and pancreas homeobox 1, MNX1, is expressed as early as the 8th somite stage in the notochord and pancreatic endoderm. HLXB9 deficient mice have complete agenesis of the dorsal pancreas, but only minimal defects of the ventral portion. 58,59, however, persistent HLXB9 expression under the control of PDX1 also leads to impaired pancreas development. 60 The dual results with HLXB9 highlight a common theme in development, which is that a delicate temporal and spatial balance of transcription factor expression is essential for proper pancreas development. Post-development, HLXB9 expression within the pancreas is maintained only in beta cells. 58,59 Neurogenin 3, NGN3, is a basic helix-loop helix transcription factor that heralds the differentiation of PDX1 expressing progenitor cells into an endocrine lineage. 61 Interestingly, NGN3 expression is downregulated after endocrine differentiation initiates. Mice completely deficient in NGN3 lack pancreatic endocrine cells. 62 In comparison, patients with a hypomorphic mutation in NGN3 develop a profound congenital diarrhea due to intestinal loss of NGN3 causing absence of enteroendocrine cells, but they do not succumb to neonatal diabetes. 63 Taken together, the results suggest that low levels of NGN3 expression are required for endocrine differentiation. 64 GATA4 and GATA6 are part of a family of zinc finger transcription factors that regulate cell proliferation and differentiation in multiple endodermal organs. 65 Mutations in GATA4 or GATA6 will lead to pancreatic agenesis in humans. Recent studies have found GATA6 is expressed in multipotent stem cells. In addition, mice models have demonstrated the role of GATA4/6 in maintaining pancreas identity. Knockouts drive ventral and dorsal buds to intestinal or stomach lineages due to loss of GATA4/6 mediated inhibition of sonic hedgehog, SHH. 66 More recent studies have demonstrated the role of GATA6 in functional beta cell differentiation. 67 Additional transcriptions factors involved in exocrine specifications include MIST1 for acinar cells and SOX9 for duct cells. Transcription factors for endocrine pathways are MAF-A, ISL1, BRN4, NeuroD, NKX6.1, NKX2.2, PAX4, PAX6, and ARCS. In addition to the critical role of transcription factors expressed from within the developing pancreas, fluctuating levels of signaling proteins from adjacent tissues and structures also control pancreatic development. Early on, Pancreas specification from endoderm requires suppression of WNT signaling, see Chapter 1, and fibroblast growth factor 4, FGF4, signaling from adjacent mesoderm. 68,69. In addition, mesodermal retinoic acid signals refine the anterior-posterior position in which the pancreas can develop. 70-72. The relation of the dorsal and ventral pancreas to their respective structures allows them to be specified differently. Early in embryonic development, the notochord is in direct contact with the dorsal pancreas and controls its development. Removal of the notochord prevents expression of pancreatic exocrine and endocrine markers from the dorsal bud, whereas CO culture of notochord with endoderm initiates and maintains pancreatic gene expression. 73. Signals from the notochord permit dorsal pancreas specification by suppressing the expression of anti-pancreatic factor SHH, which enables the expression of PDX 1.74,75. In contrast, development of the ventral pancreas is dependent upon withdrawal of FGF signaling from adjacent cardiac mesenchyme. 76. The expression of factors from other nascent organs adjacent to the pancreas, such as the heart, also regulates pancreatic development. At a later period, endothelial tissues such as dorsal aorta and the vitelline veins influence pancreas development. 77,78. In addition to points of endodermal endothelial contact, sphingosine 1-phosphate secreted by vascular endothelial cells promotes dorsal pancreatic budding. 79. Growth factors secreted by pancreatic mesenchymal cells are also important to development of the endodermal primordium. 80. The presence of mesenchyme, particularly the presence of mesenchymal factor FGF10, shifts the growth state of pancreatic progenitors from differentiation to proliferation. The importance of ensuring pancreatic progenitor proliferation is underscored by the finding that the final size of the pancreas is determined by the original number of progenitor cells present at an early embryonic stage. 81. Stromal components also influence the pancreas during development. For example, neural crest cells that migrate into the pancreas influence beta cell number. 82. Conversely, it is also likely that the pancreas contributes instructive signals to its adjacent tissues. Reemergence of embryonic factors during pancreatic injury. Several features of pancreas development are recapitulated in two clinically relevant conditions. In the first scenario, during recovery from pancreatic injury, e.g., after a bout of acute pancreatitis, several embryonic transcription factors re-emerge from within the remaining acinar cells to form new ductular complexes called acinar to ductal metaplasia. They precede the onset of recovery and regeneration of the pancreas. 83. In the second scenario, pancreatic ductal adenocarcinoma and its non-invasive precursor lesion, pancreatic intraepithelial neoplasia, develop from a similar process of acinar to ductal metaplasia, in addition to forcing the transcription of embryonic genes such as Notch, in the setting of active pancreatic CRAS mutations, 84, or by offsetting pathways such as beta-catenin. 85. Thus understanding pancreas development will be important toward devising strategies for enhancing pancreatic recovery and understanding how pancreatic anomalies or even some forms of pancreatic cancer can arise. Another area of emerging interest related to pancreas development is the search for stem cell niches or progenitor pancreatic cells that contribute to pancreatic renewal and regeneration. 86. Although it is known that acinar cells can divide during a process termed adaptive growth. 87. Several studies have suggested that some of the remaining acinar cells undergo acinar to ductal metaplasia and that this new ductular complex functions as progenitors for the neogenesis of the other pancreatic cell types. Some groups maintain that primary duct cells are the facultative progenitor. 88,89. Recently, isolated centroacinar cells, expressing the marker ALDH1, aldehyde dehydrogenase, were shown to differentiate into both exocrine and endocrine cells. 90. Others have suggested that an altogether new gland seen by electron microscopy as an outpouching from the pancreatic duct, called the pancreatic duct gland, functions as a stem cell niche. 91. As mentioned earlier, there are even suggestions that mesenchymal cells such as the PSC can become a progenitor cell. These new insights point to the complex environment of factors and cells within the pancreas that maintains its integrity and allows for renewal and regeneration beyond the initial period of development. Developmental anomalies. Annular pancreas. Annular pancreas is a congenital anomaly in which a portion of the pancreas forms a thin band around the preampullary portion of the duodenum, leading to complete or partial bowel obstruction. Fig 55.11. The incidence of annular pancreas is estimated to be between 1 in 100,000 and 92 to 94 and 3 in 20,00095,96 based on retrospective studies of patients undergoing abdominal imaging and autopsy, respectively. Strong evidence suggests that genetic factors are involved in the pathogenesis of annular pancreas. There are reports of annular pancreas occurring in siblings 97 and identical twins 98 and a 850 part 7 pancreas microduplication on chromosome 6q24.2 encompassing the utrophin gene, UTRN, was detected in a mother and her child, both of whom were diagnosed with annular pancreas. 99 Moreover, annular pancreas is more common in patients with other congenital anomalies such as trisomy 21, cardiac defects, malrotation, duodenal atresia, genitourinary anomalies, and tracheoesophageal fistula. 100,101 The role of HH genes in pancreatic organogenesis is discussed earlier in this chapter. SHH and gene defects have shown a 42% to 85% incidence of annular pancreas in mouse models. 102,103 Although annular pancreas is often diagnosed prenatally or during infancy, it is erroneous to consider it solely a disease of infancy. A second peak of detection occurs in the 4th through 7th decades of life. 101 With symptoms differing dramatically in adults compared to children. Pediatric patients not identified by prenatal US tend to present with non-bilious emesis and feeding intolerance. In contrast, adults present with abdominal pain, pancreatitis, evidence of biliary obstruction, or with nausea, vomiting, and bloating. 101 Diagnosis in children is suspected by findings on abdominal radiographs, US, or upper GI series. In adults, CT scan, MRCP, or ERCP may be more commonly used. Not infrequently, the diagnosis of annular pancreas is made at laparotomy. Duodenostomie appears to be an effective surgical treatment for bowel obstruction in these cases and is considered the treatment of choice in children and in some adult patients. Complex pancreatic surgery is more likely to be required in adults compared with children. 100,101 Following surgical repair, there appears to be an increased risk of acute and recurrent pancreatitis into adulthood. 101,104 The risk of pancreaticobiliary neoplasia is significantly increased in adults with annular pancreas. 102,105 And an association with duodenal carcinoma has been reported as well. 106 Thus ongoing cancer screening and surveillance should be considered in this population. Pancreas divissum, PD, results from a failure of the dorsal and ventral pancreatic ducts to fuse during embryogenesis, Fig 55.12, resulting in the majority of exocrine secretions draining from the relatively smaller dorsal duct of Santorini and minor papilla. There are 3 types of pancreas divissum identified. 107 Classic or complete divissum, in which there is complete failure of fusion between the dorsal duct, Santorini, and ventral duct, Wirsung, occurs in 71% of patients with PD. The second type of PD, called dominant type or dorsal duct pancreas divissum, in which there is absence of the ventral duct, occurs in 6% of patients with divissum. The last type, incomplete pancreas divissum, in which there remains a small communication between the ventral and dorsal ducts, occurs in 23% of patients. Pancreas divissum has been detected in 5% to 10% of the population in autopsy studies and in a similar percentage of patients undergoing ERCP. 108-110 Several decades ago, Cotton reported that 26% of adult patients undergoing ERCP for evaluation of recurrent acute pancreatitis were found to have PD-111, suggesting a causative link. A 2011 cross-sectional study concluded that PD should be considered a predisposing factor for chronic and recurrent pancreatitis, based on MRI. 112 However, recent papers have shown an association between genetic mutations in SPINK1 and CFTR and PD in symptomatic patients, suggesting PD in association with other risk factors for pancreatic disease has an additive effect in development of pancreatic disease. 113,114 Moreover, A recent systematic review found no clear correlation between PD and pancreatic disease. 115 It remains unclear whether PD is a cause or a cofactor in the development of pancreatic disease. A possible carcinogenic role has also been described in a case report of ampullary cancer associated with PD in 2011, followed by a retrospective review finding 7.8% of patients with PD had pancreaticobiliary tumors. 116,117 Pancreas divissum can be diagnosed by endoscopic retrograde pancreatography, EUS, abdominal CT, or MRCP. Although endoscopic retrograde pancreatography is considered the gold standard in diagnosing PD, secretin-enhanced MRCP has emerged as a potential tool, with a recent STUDY118 showing a sensitivity of 73.3% and a specificity of 96.8%. MRCP without Fig 55.11 A film from a barium contrast upper GI series demonstrating a mid-duodenal stricture, ARROW, with proximal dilatation, findings compatible with an annular pancreas. An annular pancreas was identified on CT scan and confirmed during surgery. Courtesy Michael Federal, MD. Fig 55.12 MRCP imaging of a child with recurrent pancreatitis, pancreas divissum, and a type 1 Choled-Ocal cyst. Chapter 55 Anatomy, Histology, Embryology, and Developmental Anomalies of the Pancreas 851-55 secretin was non-diagnostic. Although only a minority of patients with PD develop symptoms due to their abnormal anatomy, it appears that endoscopic or surgical therapy can relieve symptoms in some patients with recurrent acute pancreatitis and chronic pancreatitis. See Chapter 59. In 2008, a retrospective database study of 57 patients with PD undergoing minor papilla endotherapy revealed clinical improvement in 76% with recurrent acute pancreatitis, in 42% with chronic pancreatitis, and in 33% with pain alone after a median follow-up of 20 months. 119. Long-term outcomes were again assessed in a 2009 database study of 145 patients with PD who underwent minor papilla endotherapy. Clinical improvement was achieved in 53% of patients with recurrent acute pancreatitis, 18% of patients with chronic pancreatitis, and 41% of patients with pancreatic-type pain, at median follow-up of 43 months. 120 Kanth et al. Found endotherapy to be an effective treatment option for patients with acute recurrent pancreatitis in a systematic review of 528 patients. 121 Another recent systematic review examined the role of both endoscopic and surgical therapy and concluded that while both modalities resulted in symptom improvement, surgical therapies led to superior outcomes. 72% versus 62.3% symptom improvement. 122 Ectopic pancreatic tissue. Ectopic, heterotopic, pancreatic tissue, often referred to as a pancreatic rest, occurs in 0.6% to 13.7% of the population according to autopsy material. This tissue lacks a physical connection to the pancreas and has an independent blood supply. Pancreatic rests are most commonly found in the stomach, Fig. 55.13, duodenum, proximal jejunum, and ileum. Less frequently, it can be found in a Meckel diverticula, 6%, or even the umbilicus, bile duct, gallbladder, splenic hilum, colon, or appendix. 123 Although rarely clinically significant, ectopic pancreatic tissue has resulted in pancreatitis 124 ulceration and bleeding 125 intussusception 126 and malignancy. 127,128 On imaging, pancreatic rests appear as a smooth, broad-based submucosal mass with about 45% having a classic central umbilication. EUS has been used for accurate preoperative differentiation between GISTs and pancreatic rests. 129 And typical features on EUS include antral location, mucosal dimple, 3 to 4 layers, and lesional duct. 130 When necessary, endoscopic band ligation with snare polypectomy can safely resect the lesion. If symptoms are significant or histologic confirmation is needed. 131 Surgical resection is another option, but whether to remove ectopic pancreatic tissue that is found incidentally remains controversial. with pancreatic rest having rare malignant potential described only in case reports. 132 Pancreatic agenesis. Pancreatic agenesis is a rare condition that can be complete or partial. Mice homozygous for a targeted mutation in the insulin promoter factor 1 gene, IPF1, are born without a pancreas 48, and mutations in PDX1 and PTF1A have been reported in humans with pancreatic agenesis. 49, 57, 133. Most recently and significantly, GATA6 mutations were identified in 15 of a cohort of 27 subjects with pancreatic agenesis. 134 Complete pancreatic agenesis is mostly fatal because infants are stricken with diabetes and malabsorption, as well as intrauterine growth retardation due to lack of insulin, an important intrauterine growth factor. 135, 136 Partial pancreatic agenesis, or agenesis of the dorsal pancreas, may be less significant clinically owing to the presence of some functioning pancreatic tissue. Also known as congenital short pancreas, agenesis of the dorsal pancreas has been associated with polysplenia and intestinal malrotation. 137 Renal anomalies. 138 and heterotaxy. 139 A recent study has also described a new phenotype associated with maturity onset diabetes of the young due to variants in PDX1. 140 Pancreatic agenesis should be suspected based on clinical findings and can be confirmed with MRI. Congenital cysts. Congenital cysts of the pancreas are rare and may be diagnosed at any age, even prenatally by routine US. 141, 142 The cysts may be solitary or multiple, and are distinguished from pancreatic fluid collections by the presence of an epithelial lining. They are thought to form due to anomalies in the development of the pancreatic ductal system. Typically, as permanent ducts develop, embryonic ducts regress. However, when the embryonic ducts persist, they can become obstructed and fluid-filled, resulting in congenital cysts. 143 The clinical presentation is variable, ranging from an incidental finding on an imaging study to an abdominal mass, with or without vomiting, biliary obstruction, or acute pancreatitis. Solitary pancreatic cysts are often enteric duplications that may be located entirely within the pancreatic parenchyma and may communicate with the pancreatic duct. 144 Multiple pancreatic cysts tend to occur in patients with associated anomalies and may be seen in systemic disorders such as von Hippel-Lindau syndrome, Eve-Mark-II syndrome, or polycystic kidney disease. 145, 146 In a review of 15 cases of congenital pancreatic cysts, most presented before the age of 2 years, and associated anomalies were found in 30% of cases. 147 Congenital pancreatic cysts are more often located in the body and tail, 62%, of the pancreas than in the head, 32%. 148 Surgical therapy consists of total excision when possible. Cysts in the pancreatic head may be addressed using endoscopic or surgical drainage procedures, when necessary. Pancreaticobiliary malunion. Pancreaticobiliary malunion, PBM, is a congenital malformation in which a common channel for bile and pancreatic fluid is formed, owing to the absence of a septum between the ducts. Fig 55.14. Bile duct dilation may accompany PBM. The abnormal union occurs outside the duodenal wall, thus the influence of the sphincter of Oddi is lost, allowing reflux of pancreatic exocrine secretions into the biliary system, and bile into the pancreatic duct. Recent data have suggested that a markedly elevated amylase concentration can be detected in the bile of patients with a common channel of 5 mm or greater. 149 Biliary. Fig 55.13 Endoscopic view of a pancreatic rest in the gastric antrum of an 8-year-old boy. Note the central umbilication. 852 Part 7 Pancreas stasis, intermixed with refluxed pancreatic secretions, places affected patients at increased risk for biliary neoplasms that manifest in adulthood. 150 Biliary neoplasms are most frequently seen in the gallbladder. However, bile duct neoplasms can also occur with increased risk in presence of congenital biliary dilation, 32.1%. versus 7.3% in patients without biliary dilation. 151 Conversely, biliary reflux into the pancreas increases risk for acute pancreatitis. A classification for PBM has been proposed by dividing it into 3 types: a PB type, in which the pancreatic duct appears to join the bile duct; a BP type, in which the insertion of the bile duct is into the pancreatic duct, and AY type, in which there is a long common channel measuring greater than 15 mm in length. 152,153 in large series. The BP and PB types have each been reported to be the most common type of PBM. 154,155 Approximately 15% of children with recurrent pancreatitis have this disorder. 155 and chilled occal are almost universally associated with PBM, 94% and 100% in two series. 55,154 Pancreaticobiliary malunion is diagnosed by traditional cholangiography, ERCP, intraoperative cholangiography, or percutaneous cholangiography, MRCP, or helical CT scan. Traditional cholangiography remains the gold standard. The increased risk of biliary tract malignancy in patients with anomalous pancreaticobiliary union is well documented. Malunions were seen in 62.5% of adults with gallbladder cancer, in 50% of patients with gallbladder adenomyomatosis, and in 33.3% of patients with bile duct cancer. 154 Moreover, the incidence of biliary cancer is 15 to 20 years earlier in patients with PBM in comparison to patients without PBM. 150 In Japan, high incidences of gallbladder carcinomas were seen in patients with PBM, with and without cystic dilation of the bile duct. 156 Patients with PBM have increased cellular proliferative activity of the gallbladder mucosa, even in early childhood. 157 Although there is controversy concerning management of PBM among patients of various ethnic groups. 158-160 Given the cancer risk for the patient with this anomaly, consideration for cholecystectomy, resection of the bile duct, and hepatococyginostomy may be advised. 156,161